Hello. Today my topic of discussion is part 2 of hemolytic anemia. In the part 1 we have already discussed about what is hemolytic anemia, what is the relation of hemolytic anemia with normocytic anemia and hemolysis. Now in this part we are going to discuss about the classification of hemolytic anemia, rather better to say different types of classification of hemolytic anemia. So let's begin. If you are new to my channel, don't forget to subscribe, like the video and share, and get notified for the new educational videos daily uploaded in this channel. Just a recap of the last video. What is hemolytic anemia? We have already discussed the relation between the normocytic anemia and the hemolytic anemia, how it happens. Okay, so classification 1. There are two types of classification that is proposed forwarded by the various research workers. So this is classification type 1. Yes. Here you can see that hemolytic anemia is divided into two parts, or there are the classification: hemolytic anemia, inherited hemolytic anemia, and acquired hemolytic anemia. We have to understand this flow chart very well, because in the question answer session you have to answer this question if it comes for the 10 marks with total description. So please be attentive and go through like that. So hemolytic anemia is divided into two parts, or the classified into two parts. One is inherited. Inherited means uh, there are defects found in any of the components, like enzymes or membrane or hemoglobin, which can lead to hemolysis. And this defect of the membrane or the enzyme or the hemoglobin is inherited. Okay. Now, this inherited hemolytic anemia can further be classified into membrane defects, which is known as membranopathy, enzyme defect, which is known as enzymopathy, and hemoglobin defect, which is known as hemoglobinopathy. Pathy means some pathological disturbances. Okay, so membranopathy, enzymopathy, and hemoglobinopathy. Membranopathy means problem in the membrane, enzymopathy means problem in the enzyme, and hemoglobinopathy means problem in the hemoglobin. So let's discuss first about the membrane defects or membranopathy. So regarding the membranopathy, you can see two points are given here. One is hereditary spherocytosis and elliptocytosis. So these two are the types of the RBC which we are going to find if there is membrane defects or membranopathy, and which is already inherited, comes under the classification of inherited hemolytic anemia. Now this hereditary spherocytosis, it is an autosomal dominant disorder caused by the mutations in the red blood cell membrane skeleton protein genes. So here the protein is defective, membrane protein is defective, with a weakened protein backbone anchoring its lipid bilayer. The membrane undergoes a progressive deterioration in structure, resulting in the spherocyte. The characteristic abnormality is seen on peripheral smear. So, peripheral smear will tell us about this spherocytic attitude of the RBC. The spherocytes are unable to pass through the splenic cords and are degraded and ingested by the monocyte macrophage system. So, in this way, in the membranopathy, the inherited hemolytic anemia occurs. The diagnosis is based on the combination of spherocytosis noted on peripheral smear, a family history, At least in 75% of the cases, it is found that this type of problem is in the family history. The mean corpuscular hemoglobin concentration, that is MCHC, frequently is elevated or increased. So this is a brief of membranopathy of inherited hemolytic anemia. Now, regarding the enzyme defects or enzymopathy, we can say that there are two two enzymes that are very much important and which is causes the problem. One is G6pd glucose 6-phosphate dehydrogenase deficiency, which is X-linked problem, and pyruvate kinase deficiency, which is an autosomal recessive problem. Now, the most common enzymopathy causing hemolysis is G6pd deficiency, and this G6pd, it is a critical enzyme in the production of glutathione. Please remember, in the production of glutathione, which defends red cell proteins, particularly hemoglobin, against oxidative damage. So it is very important for the body. This X-linked disorder predominantly affects the men. So it is not, enzymopathy is not predominant in case of the woman. It is predominant in the case of the men. More than 306 G6pd variants exist worldwide, but only a minority cause the hemolysis. So what happens? The altered erythrocytes undergo both intravascular and extravascular destruction. So it is destructed. Older red blood cells are most susceptible because they have an intrinsic glucose 6-phosphate dehydrogenase deficiency coupled with the normal age-related decline in glucose 6-phosphate dehydrogenase level. So this is the problem in the enzyme glucose 6-phosphate dehydrogenase, and same for the pyruvate kinase also. If it is deficient, it also causes the problem in the blood cell, and it comes under the inherited hemolytic anemia. Now, regarding the hemoglobinopathy, it is another very important thing. You can see that two diseases are categorized here: sickle cell disease, which is autosomal recessive, and thalassemia. Both are very familiar to us. Now, this chronic hemolysis can be a characteristics of disorders of hemoglobin synthesis, including sickle cell anemia and thalassemia. The thalassemia are a heterogeneous group of inherited multifactorial anemia. Just this term is very important. Multifactorial anemia, characterized by defects in the synthesis of alpha or beta subunit of hemoglobin tetramer. The deficiency in one globin chain leads to an overall decrease in hemoglobin and the intracellular precipitation of excess chain, which damage the membrane and leads to clinically evident hemolysis in the severe forms of alpha thalassemia, which is also known as hemoglobin H disease, and beta thalassemia, which is intermedia and major. So this is the story of thalassemia, which comes under the hemoglobinopathy of inherited hemolytic anemia. Now, this sickle cell anemia is an inherited disorder caused by a point mutation leading to a substitution of valine for glutamic acid. Please remember, substitution of valine for glutamic acid in the 6th position of the beta chain of hemoglobin. Membrane abnormalities from sickling and oxidative damage caused by hemoglobin S leads to splenic trapping and removal of cells. So cells are removed. Hemoglobin electrophoresis reveals a predominance of hemoglobin S. Sickle cells are observed on the peripheral smear. You can see it predominantly in the peripheral smear. So, hemolytic anemia and its classification towards the inherited hemolytic anemia, there are 3 types of, and different causes are there. They are membrane, for the membrane defects, which is called membranopathy, enzyme defects, which is called enzymopathy, and hemoglobin defect, which is called hemoglobinopathy. Now, regarding the acquired disorder which is immune mediated and non-immune mediated. So, once the diagnosis of hemolysis is made on the basis of laboratory and the peripheral smear findings, it is necessary to determine the etiology. Okay? While most forms of hemolysis are classified as predominantly intravascular or extravascular, the age of onset, accompanying clinical presentation, and coexisting medical problems usually guide the clinician to consider either an acquired or the hereditary cause. So these are the points or the hallmarks on which depends whether the hemolytic anemia is classified as inherited or acquired. Now, regarding the immune mediated hemolytic anemia, you can see here there are two types: alloimmune hemolysis, autoimmune hemolytic anemia, AIHA. Please go for the abbreviations, AIHA. Now, this AIHA again subdivided into warm AIHA, cold AIHA, and paroxysmal cold hemoglobinuria. So, this immune hemolytic anemias, there are three of them, anemias are mediated by antibodies directed against antigen on the red blood cell surface. Microspherocytes on a peripheral smear and a positive direct antiglobulin test are the characteristic findings. Now, this immune hemolytic anemia is classified as autoimmune, alloimmune, or drug-induced based on the antigen that stimulates antibody or complement-mediated destruction of red blood cells. Now, regarding the autoimmune hemolytic anemia, that means this portion, AIHA, it is mediated by autoantibodies and further subdivided according to their maximal binding temperature. Please note this point, maximum binding temperature. So, on the basis of that maximal binding temperature, warm hemolysis, cold hemolysis, etc. are classified. Now, warm hemolysis refers to immunoglobulin G, IgG, autoantibodies which maximally bind red blood cells at body temperature 37 degrees centigrade. If we convert it into Fahrenheit, then 98.6 degree Fahrenheit. In cold hemolysis, immunoglobulin M autoantibodies, or which is also known as cold agglutinins, bind the red blood cells at lower temperature. That means 0 degree to 4 degree centigrade. If we convert it into Fahrenheit, it is 32 degree to 39 degree Fahrenheit. When warm autoantibodies attach to the red blood cell surface antigen, this immunoglobulin G coated red blood cells are partially ingested by the macrophages of the spleen, leaving microspherocytes, the characteristic cells of autoimmune hemolytic anemia. These spherocytes, which have decreased deformability compared with normal blood cells, are trapped in the splenic sinusoids because they can pass and removed from the circulation. So, we are loss of RBC. Cold autoantibodies, that is immunoglobulin M, temporarily bind to the red blood cell membrane, activate the complement and deposit complement factor C3 on the cell surface. This C3 coated complement factor or red blood cells are cleared slowly by the macrophages of the liver. Now, it's important to note that the direct antiglobulin test, or DAT, D for direct, A for antiglobulin, T for test, also known as the direct Coombs test, demonstrates the presence of antibodies or complement on the surface of the red blood cells and is the hallmark of autoimmune hemolysis. So, this is the autoimmune hemolysis. Now, regarding the alloimmune hemolysis, there are, you can see, that hemolytic disease of the newborn and hemolytic transfusion reaction. So this transfusion reaction is a thing to be understood. The most severe alloimmune hemolysis is an acute transfusion reaction caused by ABO incompatible red blood cells. Okay, let's explain with an example. For example, transfusion of A red cells into an O recipient who has circulating anti-A immunoglobulin M antibody leads to complement fixation and a brisk intravascular hemolysis. Within minutes, the patient may develop fever, chills, dyspnea, hypotension and shock. So this type of problem occurs in the hemolytic transfusion reaction in alloimmune hemolysis, which is immune mediated. Now, these are all regarding the autoimmune hemolytic anemias. Now, regarding the non-immune mediated non-immune mediated acquired hemolytic anemia, we can see that there is mechanical trauma, that is prosthesis, microangiopathic hemolytic anemia, which is also known as MAHA, then infections by malaria, clostridium, then renal disease, drugs and chemicals, hypersplenism. These also can cause the non-immune mediated hemolytic anemia. So, regarding this microangiopathic hemolytic anemia or MAHA, it is very important. It is also known as fragmentation hemolysis. Please note the word fragmentation hemolysis. It is caused by a mechanical disruption of the red blood cell membrane in circulation, leading to intravascular hemolysis and the appearance of cystocytes. The defining peripheral smear finding of MAHA, the abbreviation MAHA, M for microangiopathic, A for angiopathic, H for hemolytic, A for anemia, microangiopathic hemolytic anemia. When red blood cells traverse an injured vascular endothelium with associated fibrin deposition and platelet aggregation, they are damaged and shredded. Okay, they are damaged and shredded. This fragmentation occurs in a diverse group of disorders, including thrombocytopenic purpura, TTP, you can see here TTP, then hemolytic uremic syndrome, HUS, you can see here HUS, then disseminated intravascular coagulation, you can see here DIC, then preeclampsia, eclampsia, malignant hypertension and scleroderma renal crisis. It's given here, renal disease. Okay. So in addition, intravascular devices such as prosthetic cardiac valves and transjugular intrahepatic protosystemic shunts also can induce MAHA. Sorry. So regarding the infection, malaria is a classical example of direct red blood cell parasitization. Now this Plasmodium species introduced by the Anopheles mosquito, what they did, they invade the red blood cells and initiate a cycle of cell lysis and further parasitization. Now, both the cellular invasion and the metabolic activity of the parasite altered the cell membrane, leading to splenic sequestration. Sequestration you all know. We have gone through in iron deficiency anemia, sequestration. Red cell lysis also contributes to the anemia and can be dramatic in the case of black water fever, named from the brisk intravascular hemolysis and hemoglobinuria that accompany overwhelming Plasmodium falciparum infection. The diagnosis is made by the observation of intracellular asexual forms of the parasite. Mind, intracellular asexual forms of the parasite on thick and thin blood smear. So, whatever the way you make the blood smear, you will find that. Similarly, Babesia microthi and Babesia divergens, tick bronprotozoa, and Bartonella bacilliformis, a gram-negative bacillus transmitted by the sandfly, cause extravascular hemolysis by the direct red blood cell invasion and membrane alteration. Now this septicemia caused by Clostridium perfringens, which occurs in intra-abdominal infections and septic abortions, causes hemolysis when the bacterium releases alpha toxin. Releases what? Alpha toxin, a phospholipase that degrades the red blood cell membrane. So we can say that these Clostridium, they actually work at the membrane level. So it can also be considered as a membranopathy, but the cause is something different here. Cause is the infection by some parasites. So this was the story of classification number 1 of hemolytic anemia. Now regarding the classification 2, it's very simple, that there is intracorpuscular and extracorpuscular, two types of anemia, means hemolytic anemia. We already gone through all this. You can just have a look here. All we have discussed, but in a separate way. So it's a simple classification, and that is the somehow complex classification. If the classification comes in the question, you have to give both. So here are some references for your further study. So thank you very much for your patient listening. Hope you have understood well. Now, one suggestion is there, that when you are copying the notes, please go through my lectures also, because all my lectures are not given here in the written form. So please listen minutely and copy my lecture also. So continue to part 3, where we are going to discuss of some other aspect of hemolytic anemia. So long.